Hey everyone, my name is Cody Johnston, and I'm the audio engineer here at Positive Recovery MD. I wanted to hop on here real quick before we get to our scheduled episode and give you a quick disclaimer. COVID has many of the common tools we use in the podcasting industry, like Zoom for instance, pretty bogged down. Regrettably, we experienced this firsthand this week as Dr. Jason and Julie had an amazing conversation with this week's guest, Dr. Elizabeth McIngvale. Despite losing our high-quality recording in cyberspace, we were fortunate enough to be able and recover Dr. Elizabeth's audio via phone-in call. So this week's audio quality isn't on par with our desired standards, but we can't let such an amazing conversation go to waste. So please excuse our technical difficulties and tune in to a fantastic conversation with Dr. Elizabeth McIngvale about how OCD, anxiety, and addiction are all related.
Welcome to Positive Recovery MD. If you're listening, chances are you want to create happiness around you and thrive in your life. We're glad you're here and you've come to the right place. This podcast will inspire and motivate you to not merely survive your recovery journey, we'll give you the tools to build or strengthen your foundation to thrive and flourish in your life. Each week, we'll come together as a community to have authentic conversations around addiction, recovery, and what matters. Growth and progress, not perfection. All while developing positive habits for you to utilize in your life. To learn more, please visit positiverecoverymd.com to sign up to receive the daily positive interventions that we'll review, as well as gain access to exclusive Positive Recovery content available only to Positive Recovery MD listeners. All right, let's get started.
Hi, I'm Dr. Jason Powers. Today's another episode of Positive Recovery MD. I'm here with Julie Denova.
Hi there, President of Positive Recovery Centers, and I'm so excited today to have the guest that we have on. We have Dr. Elizabeth McIngvale, and wow, so excited to have you on the call. Thank you, Elizabeth, for joining us.
Yes.
Thank you. I'm so excited to be here and looking forward to it today.
Yes, it's a small world. So I grew up in Houston. You obviously did some growing up in Houston. My family was in retail, and I used to watch my grandfather do commercials with your dad when he used to hold a wad of cash and say, save you money on commercials during WWF, the wrestling. This was pre-Hulk Hogan. This was just unabashedly fake. Not that it's that real today, but, and also your niece, Sydney, is in my daughter's class at Schlenker. So welcome, and Julie's going to let all you listeners know a little bit about our guest.
Dr. Elizabeth McIngvale is the founder of Peace of Mind Foundation and the director of the McLean OCD Institute at Houston, where she maintains an active clinical research and leadership role. Her clinical interests focus on OCD, anxiety disorders, mental health stigma, and access to mental health care. Like I said, she's the founder of the Peace of Mind Foundation, a nonprofit foundation dedicated to OCD. Dr. McIngvale operates OCDchallenge.org, a free self-help website for OCD, which is live in 6 languages and serves nearly 4,000 individuals. She was the first ever national spokesperson for the International Obsessive Compulsive Foundation and now serves on their board of directors. She received her bachelor's and master's degree in social work from Loyola University Chicago, her PhD in social work at the University of Houston, Go Cougs, and is currently pursuing her MBA from Kellogg School of Business Management at Northwestern University. Dr. McIngvale engages in advocacy, clinical work, research, and teaching related to OCD and anxiety disorders. She is a renowned speaker on both the local and national level, speaking on behalf of OCD, mental illness, and mental health stigma. Dr. McIngvale has received numerous awards for her advocacy and impact on the mental health field and currently serves as a director on 5 boards. She is internationally known and recognized for her clinical work and advancements in the OCD field. Dr. McIngvale is dedicated to giving a voice to the voiceless and is grateful for a career which allows her to improve the lives of those living with a mental illness every day. Thanks so much for being here.
It's my pleasure. Thank you for having me, and I'm excited to connect and share and think about ways we can further serve our community.
Yeah, so one thing came up for me when I heard that you were going to be our guest was learning about OCD. And, you know, I'm a physician, board certified in family medicine and addiction medicine. And there's always been this like undercurrent of similarities between OCD and addiction. Just, you know, maybe like a superficial understanding, but I've been reading voraciously and I'm probably going to put my foot in my mouth thinking I know a thing or two just from hearing, but I've listened to so many case studies. There's a lot of similarities that kind of stand out. Like one of them for me, I knew something was wrong with me, but I didn't know what it was, and I felt all alone. And I know that's a pretty common theme that happens. The shame also of, being an addict it's tough because you're judged. It's not something that we readily tell each other. Just like somebody who's got OCD, maybe if the intrusive thoughts are, oh my God, what if I am a pedophile? Or like, how do I tell somebody that I don't believe I locked my front door, or, that they're OCD, dirty, that I have to wash my hands? And it's just one of those things that stands out. And of all the case studies I was listening to, getting an understanding of it and getting with other people helped tremendously, just like with addiction. And so what you do at your institute, I'm sure there's different levels of care, correct? Where you take care of people in the community. So tell me a little bit about sort of what you guys offer.
Yeah, so we offer really three main levels of care. So it's, I say traditional, but traditional outpatient. So typically that's, once a week, 45-minute outpatient therapy sessions. And then we have really our more intensive program. So this is often our partial hospitalization program, which is treatment from about 8:30 in the morning until 4 p.m. daily. And then we also have our residential support where patients live with us. They're with us 24 hours a day and receiving support and care at all times.
So you have inpatient, like how many beds?
Yeah, so it's not inpatient because it's not a locked unit. They can come and go. So there's more flexibility and less acuity for sure. But we have 11 beds and we do have residents who live on site.
So I was just listening intently to what Dr. McIngvale was saying and just looking kind of like Dr. Powers was saying in terms of the similarities between the two. And so what are the ways, Elizabeth, that OCD is treated best?
Yeah, so really it's often a combination of therapy and medication. But what we know is that individuals have to be engaging in appropriate therapy. But therapy alone doesn't work, So when people will say, a lot of people say, oh, I treat OCD, I treat anxiety, but they don't have a specialty in OCD. They don't specialize in it. It's not their real background. And so often these traditional talk therapies, supportive therapies, or even kind of general cognitive therapy is not going to help somebody get where they need to get if they live with OCD. In fact, they need a specific form of cognitive behavioral therapy, which is called exposure with response prevention, also known as ERP. And this treatment is specific. It's individualized, of course, to patients' symptoms and how they present and how their OCD presents. But ERP is critical when it comes to the treatment of individuals with OCD. Medication is valuable, and a lot of our patients use it and benefit from it, but they have to have ERP no matter what, because that's really the tools that help them get to where they need to get in treatment, but also that will help them be able to maintain their symptoms throughout their life.
I love saying that there's no skill in a pill. So when patient, and so with OCD, there's several pills, right? There's several medications that help, but at best they're an adjunct, right? So explain to us, assume many of our listeners don't know what ERP is. I just want to give a little bit of a historical context.
No, I was just going to say, I love the no skill in a pill. I've never heard that. And so I'm sitting here like, I gotta write this down because my patients will love to hear that. Because they want a cure. They want a medication, as do I. Like, I want anyone with OCD to be able to take a medication, not worry about it. But it doesn't come with those skills you get to carry with you forever. Yeah,
exactly. So something I also tell patients that I guess equally proud of, as there's no skill in the pill, although I didn't coin that one, is, they're looking for an easy way out. They want everything done yesterday. They don't want to work for it. And it's just human nature, I think, is the immediate gratification piece. But, if I could bottle time, then I wouldn't have much work to do, right? And that's only to say that with the right therapy, it takes time, right? It takes baby steps, and it's sort of, you have to do it incrementally and you have to stay in the moment. Again, a lot of similarities between our two. Historically, when doctors I guess the new Western allopathic medicine started branching off and having the psychiatry and then the physical different schools of medicine, psychiatrists actually did a strange type of exposure to people with OCD. You're probably aware of this, but they would have patients who were germaphobes sit in their office, in a psychiatrist's office, and play with feces. They would force them to do that disgusting exposure. I know. We've come a long way. ERP is nothing like that today. So,
God.
Yeah, why don't you walk us through what it's like today?
Yeah, I'm making a face because I'm thinking, the first thing I always tell patients, because the biggest concern is, what are you going to make me do, right? And with really any therapy, anytime we think about what we're in treatment for when it's anxiety-based is usually an underlying core fear or concern. And so there's this anxiety of how far are you going to push it? What are you going to make happen, right? Somebody who has a common OCD fear of blood-borne illnesses like HIV, our goal is not to make them contract HIV, right? Or to put them in a situation where they're at risk of contracting HIV. Instead, our goal is to get rid of this irrational fear and to be willing to take risks that everybody else takes every day that aren't actually true risks, although it feels, because of your OCD, like it's a true risk, right? People feel that getting a drink from Starbucks with a barista who has a Band-Aid on is risky and is dangerous, and maybe they need to go get tested after that, where those of us who don't have OCD or individuals who don't have OCD can know that that's irrational and that that's not how the disease is contracted. And I will say, people with OCD, we know it's irrational, and that's what makes the disease so bizarre, but fascinating to me is that we know it doesn't make sense, but the anxiety and the physiological response make it feel so real that it's hard for us to just lean into our insight and say, oh, we know this is ridiculous, versus this is OCD. And so what is ERP, right? It's actually exactly what it sounds like. It's exposure with response prevention. And I'll unpack that a little bit. But when we think about trauma work, or we think about panic disorder or anxiety disorders, right, we've heard of exposure therapy. The point in the process typically is that we expose you to what you're afraid of, right? We have you face your fears, right? If you have a fear of flying, the goal is to get on a plane one day and fly. If you have a fear of heights, we might take you on a carousel or something like that, right? And so, again, it's about being able to slowly and systematically expose us to our fears. And so when you think about somebody with OCD, if my doorknob in my office is contaminated, and an exposure therapy is to touch the doorknob, right? That's great. They touch the doorknob, they've done an exposure, they've faced their fear. But if somebody, which is typical for people with OCD, walks down my hall to the bathroom, doesn't touch anything in between, uses the other hand to turn the faucet on and washes their hands, guess what? Like, we no longer actually have helped their OCD, we reinforced it because we did an exposure, but we didn't do it with response prevention. So when people say I treat OCD with exposure therapy, you're not an OCD specialist, you're probably not treating OCD, because exposure therapy, actually, people with OCD do every day. If they're not totally isolating, they have to do exposures. But if they do rituals, they reinforce the cycle, they reinforce the illness. And so exposure with response prevention is that we face your fears, but we prevent you from engaging in that response. So you touch that doorknob, but you don't engage in that hand wash. You don't do the normal response that you usually do to feel better. We do it slowly and systematically, right? And there's a couple rules when it comes to ERP in my mind that should be always in place. The first is that it's never surprise, right? You don't walk in my office and I say, guess what? This is what we're doing today. No, like, we've discussed it together. We feel comfortable. We're both on board. The second is that I, as a provider, should do the work with you. We do these exposures together. We sit with it together, and you see that, like, oh, Liz is willing to take the risk. Liz is willing to do it with me. Sometimes that becomes a little reassurance seeking, and eventually I want you to do it on your own. But the point is that the most important part of exposure is number 3, which is what goes so far against this whole feces.
Number 3 is no feces.
No feces, right? Because I should never ask you to do something I'm not willing to do, right? Exposures shouldn't be dangerous. They shouldn't be risky. They shouldn't actually put people in harm's way. Exposure should be things that anyone would be willing to do, right? Now, you might not want to get rid of COVID and pretend it doesn't exist, right? You might not want to sit on the parking lot and touch the ground and then eat lunch, right? You might think like, I don't know if I would do that. That's like kind of gross. But I bet if I asked you, could you do it? You would say, yeah, I could, and I would, right? It feels gross, but it doesn't feel dangerous. It doesn't feel risky. Where the person with OCD feels like that's dangerous and risky. And so we're teaching them that everyday risks, right? Like, we have to push the envelope a little bit, but it's still risks that I'd be willing to take and I'd be willing to do with them.
And what you don't do is just throw them in the deep end of the pool. It sounds like there's incremental exposures with prevention of those rituals. And
yeah, so if someone who's, on a path to sobriety, you wouldn't week 1 tell them to go ahead and go back to that bar that is the most triggering place for them and sit in the bar and see what they do.
At least 2 weeks. We tell them wait at least 2 weeks.
Right. It's slow and systematic.
Right.
We have to work our way up. We have to hone our skills. And it's much like I tell people about deep breathing, right? If you believe in, like, not believe in, if you like deep breathing and diaphragmatic breathing and you think it's helpful to calm down, I'm not going to teach a patient deep breathing skills for the first time when they're in the middle of a panic attack, right? Yeah, like, guess what? You're not going to be able to do it. But if I teach you when you're calm and collected and you hone in on the skills, then when you have a panic attack, it's much easier to use it and to, really to access it. And so we do it in what we call a hierarchical manner, right? We create this hierarchy where we want patients to rate their anxiety on 0 to 10, 0 being none at all, 10 being panic attack. And we say, okay, how hard would it be for you to touch the doorknob in Liz's office? Maybe that's a 3. How hard would it be for you to touch the doorknob in a public bathroom? Maybe that's a 7. How hard would it be for you to touch the doorknob at the hospital? Maybe that's a 10, right? I'm just making things up, but we slowly work our way up. We don't start with the highest level because that RP is more important than the E, right?
Right.
The risk prevention is more critical than the exposure. So for me, if a patient does a high-level exposure and they feel great, they did this high-level exposure, but they ritualize, I didn't help them. I've reinforced their OCD. I would much rather a low-level exposure without ritual so that they can retrain their brain that, oh, I actually don't have to do anything at all when I feel uncomfortable and when these intrusive thoughts come.
Right, and that's exactly how we address cravings. And because cravings seem overwhelming, and people are operating on autopilot. So sort of like you can engage in this ritual to overcome the obsession and do so automatically because you've just done it so many times that you do it without thinking. It's like driving to work and you don't realize how you got there. People joke that my car likes to drink too because it takes me to the liquor store, right? I think the one difference is like I tell my patients, like especially who are alcoholic, I was like, look, if you don't need to go to a bar, like you don't go to a bar. It's just silly. Like, why would you go to a bar to get a Diet Coke? It's like going to a brothel for a kiss, right? It doesn't make any sense. But on the other hand, sobriety or being in recovery is about leading a full life. It's not about isolating. So there's times where you go where alcohol is served, or you might go to a party like at a bar, having tools around that. So having somebody safe with you or somebody you call before and after, having an exit strategy. So there's all these things to do like the R and P and E. Tell me if this is one of your pet peeves, because, after listening to all these case studies and listening to their suffering, it's now one of mine. And I'll say a caveat that OCD, the disorder, is very different than the personality type. It said, all doctors should have some OCD personality type, because if you don't worry a lot about, making a mistake, you might make one that could be avoided. And that's one of my best friends who's a surgeon says that, and he's an incredible surgeon. So like, I'm constantly thinking about, drug interactions and new protocols and things like that. Or if I've got a complicated case, that's not OCD, right? OCD is one of those terms that's thrown out a lot, like a picnic blanket, like, and it really does to me. Now I'm mad. I don't even have OCD. And I don't like when people say it because of all the suffering that happens. Like there's a huge difference between worrying about maybe getting on a plane. Like my son, when he was 5 or 6, decided he's not getting on a plane. And he went to therapy and we did a segmental exposure, but it's not the same thing as OCD, right? What are your thoughts on that? And please tell me you're at least a little bit as mad as me. Otherwise, my anger is displaced.
I don't know if it frustrates me or makes my blood boil, and I've actually kind of coined the slogan around it, which is that OCD is not an adjective, right?
I love that.
Like, you wish you had a little bit of OCD. No, you don't. OCD is not helpful. OCD doesn't make you a better surgeon. OCD doesn't make you more organized. It doesn't make your kitchen more clean. OCD is destructive, it's disabling, and it impacts and ruins every facet of someone's quality of life. Now, when we think about obsessive compulsive personality disorder, right, OCPD, that might be more of what some people are talking about, right, which is that, like, a lot of surgeons do talk about when they're in the operating room that they like their instruments laid out a certain way. They like it handed to them, and they talk about how it actually makes them feel less chaotic, right? It feels more organized. It's how they function, and it's kind of something that, like, soothes them, right? That there's a system in place. That is not OCD, because, again, OCD is destructive. OCD is not helpful. OCD brings no pleasure. There's no enjoyment in it. That may be OCPD, obsessive compulsive personality disorder, but, again, that is totally different presentation-wise, and I kind of get frustrated that they even allude to being similar, because it makes people think that, oh, well, people with OCD don't really hate their obsessions or hate their compulsions. Yes, they do. These are unwanted intrusive thoughts followed by repetitive behaviors that we do to feel better. We don't like the obsessions. They cause us extreme amounts of anxiety, distress, and we hate the compulsions just as much. We don't want to do them. We don't enjoy them. We do them because we feel like it's the only way to feel better. And so my response or the biggest thing I would say is OCD is not an adjective, and there's not many things that frustrate me more than when people use it as one. Okay, good. At least the anger's not too displaced.
Yeah, you two definitely share that now. And what I heard when Dr. McIngvale was speaking was a lot of what we feel and kind of have with our clients in terms of in addiction medicine, right? Those same exact type of feelings. And so I was sitting here in the studio nodding my head and just grateful when someone speaks the same language that I do. For our listeners out there, I was just wondering if you might share a little bit about this idea that people sometimes talk about, that OCD manifests around areas that are closest or most important to you. This kept coming up for me when I was doing some research, and I was wondering if you could speak to that a little bit in case anyone who's listening might have read some of the same information.
100%, and it does. So really what we find is that OCD often attaches most to our values, our relationships, our faith, right? Things that mean the most to us and that are still really, really scary, right? It's pretty rare that someone with OCD is anxious and worried about something happening to like a random stranger that they don't care much about, right? Maybe they have that fear too, but usually it's, the core fear is usually, am I a bad person? Did I cause harm to someone else? Is something bad going to happen to me? Am I true in my faith, right? Is this relationship real and meaningful? Did I lie? It's often rooted in morals and values, and does that mean that OCD has to be rooted in morals and values? No, but what it tells us is that OCD latches on to the things that mean the most to us, right? People with OCD don't have unique thoughts. They did a research study where they were looking at people with OCD versus people without OCD's intrusive thoughts, and they had them both record them into like a video recording, and then the therapists were going to decipher who were the individuals with OCD and who were the individuals without. Guess what? They couldn't differentiate because everybody has weird thoughts. Everybody has bizarre, intrusive thoughts. The difference, though, is how we respond to them, right? Most individuals have driven down the road and had a thought of driving their car off the road, right? And they think, oh, it was weird, and keep driving and don't think about it again, right? And forget they even have the thought, to be honest. Versus someone with OCD has that thought and might get stuck on, does that mean I'm going to do that? Does that mean I want to hurt somebody else? What does that say about me? What does it say about who I am as a person? Like, maybe I shouldn't be driving. I must be a danger to the road, right? And next thing you know, they're engaging in avoidance behaviors or compulsions or reassurance seeking around if they hurt someone, if they're going to hurt someone, if they might act on it. And so we do find that OCD, at least it attaches to the things that mean the most to us. Are the thoughts specific and unique? No, but if you have random thoughts and they're focused on things that are really valuable to you, it makes more sense if you have OCD that that's where it grabs a hold versus things that aren't really that relevant.
Yeah, so I don't want to get very existential, but one of the favorite things that I like to talk about with patients with substance abuse disorder, among other things, is there's this urge to try to control things, right? The uncertainty of life is one of the driving forces. So because life is uncertain, that's just the way it is. The Greeks knew this, which is why the Oracle at Delphi, which was the prophet they would go to, or at least in the myths, to get answers to perplexing questions, always was answered in a question. Because the Greeks knew if you don't know how to deal with uncertainty, you're screwed. Probably, excuse my French, they didn't say that. But addicts will try to control things. Actually, people with mental disorders. I want you to maybe speak on that because, eating disorder is the same thing. It's a type of control. And if they've got an eating disorder and they have a substance abuse disorder, when they get in treatment, oftentimes the only thing they can control is their consumption. So that will come up. What are your thoughts on the whole, learning to deal with uncertainty in terms of recovery from OCD?
Yeah, that's the entire principle of treatment, right? The entire principle of OCD treatment, no matter what we do, is about being willing to be uncertain, being willing to lean into that, right? The reality is that where OCD attacks is I want to know. I want to know I didn't hurt someone. I want to know things are okay. I want to know something bad isn't going to happen. I want to know I'm safe. We never know, right? There's not many things in life we're totally certain about. Now, of course, OCD takes it to the extreme, right? If you ask me right now, is your mom okay and safe? I would say, yeah. And you say, well, how do you know? And I say, well, I don't trust that I haven't heard otherwise, so I know. Do I actually know for certain? Of course not, right? But I'm leaning into uncertainty enough that, I don't have a reason to believe otherwise, so I'm just not going to spend my time worrying about it. Compared to OCD latches onto that, right? I want to be certain. I want to know for sure. I've got to call her. I've got to talk to her. And if I can't get a hold of her, then I'll call someone else. And as soon as she answers, I'll feel better. But then in 5 minutes, I need to call again because I'm not sure. So really the whole principle behind OCD treatment and ERP is that we're leaning into uncertainty. We're willing to live with uncertainty and calculated risks that everybody else lives with every day.
That's perfect. And also addiction, like any diseases, like many diseases actually, is chronic. I used to get, my blood would boil when people would sort of expect a cure with like one episode of treatment, or I guess people in the medical field would look at addicts and alcoholics that would relapse and think, it's a characterological flaw. But, there was a landmark paper that came out comparing outcomes of substance abuse to asthma, diabetes, and high blood pressure, and they found that they're all pretty much the same. So people with substance abuse disorder, more likely than not, will have a relapse. That's just like life. Like somebody with high blood pressure is going to have a relapse. Now, somebody with OCD, let me just pose this hypothetical, say that they've gone through ERP successfully and they haven't had an episode for a year and a half, and then they have one. Does that mean they have to go right back to treatment?
This is a question that we toy with every day. I was running relapse prevention group yesterday here, and one of the things that we spend a lot of time is talking about the difference between a lapse versus a relapse, right?
Yeah, I've heard that, right.
You're going to have lapses, and I actually would be shocked if you go a year and a half without multiple lapses. To me, a relapse is kind of like your return to baseline of before treatment. And so do you have to have a full-blown relapse? Of course not. But my goal is that actually when you have lapses along the way and you find yourself ritualizing, you find yourself giving in, that's when you would seek out treatment versus waiting until it's a relapse. And the answer is, in short, most people see amazing relief from ERP in about as little as 12 to 16 sessions. I myself went to inpatient treatment when I was 15 for 90 days, relapsed about a year and a half later, went back to treatment for a couple of months, and I still go to therapy every week, right? I'm 17 plus years in treatment, and that's what works for me. And I have no shame in it. I know it's what keeps me healthy. I know it's what keeps me accountable. And so there is no right or wrong. And so to answer, do you have to be in treatment? Look, I do this for a living. I don't probably have to be in treatment right now, but it helps hold me accountable, so I want to be in treatment right now. But if I couldn't, right, if I lived in a place where treatment wasn't accessible or for financial reasons I couldn't afford treatment, I absolutely could use the tools and do the treatment on my own, right? Because you get the tools. You get to become your own therapist. You have to learn how to deploy them and what that's going to look like for you in your everyday practice.
And that's important too, because it's not so much the thought or the specific fear that's the problem, right? Because OCD can come out sideways and it can create something else. So like in substance abuse, somebody who is an alcoholic can't start using heroin, right? It doesn't really matter what the substance is. If all drugs of abuse kind of work in the same center, we talk about addiction as a global thing. So, to be able to be your therapist is great, and having the tools, no matter if the thought is what you're used to and what you went to therapy for, or maybe it's a new one.
The thing is what I tell people is that there is no cure, right? I can't make you not have intrusive thoughts, because again, everybody has them. We can talk about how you respond, but I can't get rid of that. And so I always say I'm one trigger away from a lapse and one trigger away from a relapse. But guess what? Today, I'm in management. And so when we were speaking about a second ago, it's just so empowering, is like this thought of we're going to do a couple sessions or one session, there's going to be a cure, right? No, it's management. And I look at it much like someone with diabetes, right? Someone with diabetes doesn't go into a diabetic coma, go to their physician, get better, and walk out and never worry again, right? They are put on a regimen for the rest of their lives oftentimes. That includes insulin and adjustments and measurement, and sometimes you have good days, sometimes you have bad days. No different with mental health, with mental illness, right? Brain disorder is no different than disorders of the body, and we have to change the way we look at them. And this kind of concept of, just toughen up or pull yourself up by your bootstraps.
Just stop it, right? Just stop it.
Yeah, you've gotten treatment, you know how to do this. And it's like, yeah, okay, you're right, I've gotten treatment, and you're right, I know how to do this, and I'm managing. And that's what successful outcome is. That's what a successful outcome is.
Yeah, we all have intrusive thoughts. Edgar Allan Poe called it the perversion of the imp. It's that voice inside you that says, swerve your car, or if you're on a building, jump. I know a lot of people have heard it. I've heard it, and I'm thinking, where the hell does that come from? And I can imagine if I had OCD, if I was young, especially, and not knowing what I know now, I might think I was schizophrenic, right? Like the voices, I'm sure there's a lot of misdiagnosis that goes on. Maybe mania.
Yeah, actually,
right.
There's like a common form of OCD where individuals with OCD worry about having a misdiagnosed illness. So they will become panicked that they have schizophrenia or that they have this undiagnosed mental health condition and that maybe they are a dangerous person or maybe they are going to act out on it or they're going to lose their mind and can become really trapped in that cycle.
And there's also something called meta OCD, right? Where you worry you don't have OCD.
Oh, yeah. I think most patients go through that, especially when they're feeling pretty triggered of like, well, maybe it is an OCD and I actually do want to do this, right? Maybe I actually am this type of person. That's the fear.
Yeah. Well, we have the opposite problem. We have a lot of patients who are in denial that I'm not an alcoholic. 12 DWIs, that's normal, right?
For our listeners who are kind of listening and wondering like, oh my gosh, that sounds like me, or that sounds like my son or my daughter or my husband, or these are things that I see in my own household. Just wanted to know, Dr. McIngvale, if the OCDchallenge.org would be a great place for them to start to kind of look to see how they can get some initial help or care, or what would your recommendation be?
My first and foremost recommendation would be find a provider. Find a provider who specializes in OCD treatment, and feel free to contact us at the Peace of Mind Foundation, which is peaceofmind.com, and we will be happy to help you navigate that system, right? We've got options for people kind of no matter what your financial background is and where you're at, we can try our best to connect you with a true OCD specialist. OCDchallenge.org, self-help workbooks, they're great, they're amazing tools, but I wouldn't recommend them as a replacement for therapy. I think they're often an adjunct or supplement. You really want to have at least a little bit of in-person or tele, as it is right now, but face-to-face work where you can hone the skills, you can understand the appropriate tools before you dive in.
And what about for the family members? I know like your dad has been just such a big supporter of you and all that you're doing. And I heard one of the videos, I guess when you received the Hope and Healing Award, that he just like said, like, Elizabeth, you're such an inspiration to others and that you're living a life that is built to help others. And so with you being such a helper and your family being so involved, what would you say or recommend to the families that are listening?
I think the most critical piece is you are their family. They need to feel loved and they need to feel supported. When we feel judged from our symptoms, or if we feel as if you're kind of increasing that stigma, right? Saying things like, well, you don't need to do that. Why are you doing it? Well, we know we don't need to do it, but we feel like we have to do it. Like, do you think telling us is going to make us feel better or not? And so I really would say it's just critical that you support them and that you love them and that you remember you're actually not their provider. For me, when I had family members trying to tell me what to do, tell me how to do treatment, my response would be like, because you're my clinician? And it wasn't helpful, right? I remember actually my mom and my provider saying to my mom, like, don't answer and you need to not do this and not do that. And my mom finally looked at him and she was like, you're her doctor, not me. I'm her mom. Like, I want to love her and support her, and you need to do the work, and I don't want to do it. And he was like, fair enough, right? But it was. Her point is like, I want to love my child. I want to be there with them and support them when they're struggling. I don't want to be this authoritative therapist saying, don't do this, don't do that, because like that's not my role, right? Like it creates problems when I try to get into that role. Now, of course, parents are instrumental in OCD treatment and outcomes because they are really the ones who often hold people accountable of, no, I can't give in, we agreed upon this. But again, do it with the treatment team, right? You work together with your provider to come up with a treatment plan so that the patient isn't surprised when mom says no. The mom knows the plan when they're supposed to say no, and you've agreed upon it prior versus mom or dad throwing surprise exposures. And, I think for me, people will say, like, what was one of the most important things for you in treatment and in management? And, I think the one thing the AA model does beautifully that we can all learn from for mental health providers is the final step becoming a sponsor, right? And this incredible thing that happens for us when all of a sudden we can turn our pain into purpose, right? We can find meaning in the fact that I didn't want OCD, I would do anything to not have it, but the fact that I can use it for good and I can help someone else with OCD and I can hold their hand and help give them it gives you a purpose for it, right? You not say you're grateful, but you understand the suffering enough to say something good could come out of it. And I think for me, my parents, surprisingly, because I still don't totally understand it, because my parents having the influence they have in Houston, they could have easily gotten me treatment say that was life-changing for me because I never felt stigmatized. No matter how weird the thoughts were, I was 15, in and out of treatment centers, in and out of school, couldn't shower, I was disheveled. I mean, you could visibly tell my illness had taken over my life, but my parents never made me feel ashamed. And I don't think there's any greater gift you can do for someone with a mental health condition than that.
You know what? Give your parents hugs for me, because I want to hug them now for being who they were to you. That's awesome. And I was speaking with a patient today who's got 9 months, and we had a great deep conversation about how grateful we both are to have addiction, because otherwise we wouldn't have had to examine our life at the detail that's required for this type of illness. Same with OCD. You know, listening to what your dad says about you and the fact that, you know, you've got purpose in treating people. Okay, me too. But, you know, speak to how gratifying the work is when people get better with OCD and they're not, you know, they don't turn around and then help other people with OCD, but they turn around and just thrive like as pilots or teachers or whatever. Isn't it the most gratifying thing?
It's the best thing ever.
It is.
I have patients right now here who we're meeting next week so they can talk about if they should change their career path, because they look at what I've done and they want to be a part of it. And, you know, there's something about having a lived experience that can't be replicated. You know, my parents love me. My sister and brother love me. They would do anything for me. But they don't know what it's like to live with OCD. And there's something about when you're working with patients and they can relate on a level that is so different. Do I think you have to have OCD to treat OCD? Of course not. My provider didn't. He saved my life. But I do think that for those of us who have OCD and treat OCD, there's just nothing like it.
Touche. Agreed.
Today's positive intervention, and I know that I had forwarded over to you, Dr. McIngvale, so hopefully you had a chance to look at day 8. It was kind of perfect for this and for you and for us. We were talking about journaling about the assignment, and one of the things was, what did you do today for someone else, and how did it feel? I imagine every day you're doing something for someone else. And so if you can share a little bit about that and reflect on what you have become by accomplishing some of your past goals, and is what you have become more valuable to you than what you got. So can you share a little bit about that?
Yeah, thank you. And, you know, I think that I'll leave with a story that I remember. I was meeting with Dr. Drew, and we were talking, we did a talk together, and he's, you know, as many people know, a big addiction therapist. And I asked him, you know, we were talking about different things, and he said, you know, I'll never forget, I had a patient once who came in and had this awesome pair of tennis shoes on. And I said to them, you know, God, I love your shoes. They're awesome. And he said they responded and just said, thank you, like, I appreciate it, and left. And he said the next session they showed up with a brand new pair of shoes in a box wrapped for me. And my response was like, thank you, but like, that's not why I complimented them. Like, I don't need a gift. I'm like, that's like, I don't expect a gift. That's not what I want. I was just telling you how awesome those are. And he said, and their response just stuck with me so much, because their response was, I know you don't want to take the shoes because of our relationship, but I need you to take these shoes today. Taking this gift and allowing me to do something for you is what's keeping me sober. And it just hit home to me with my illness, because what I've learned is that when I do my own work, it's good, helpful, makes a big difference. But when I serve other people and I feel like there's meaning coming from the work, meaning for them, not meaning for me, it ends up serving me more than anything I could ever pay for, buy, own, any degree I could ever get and put on my wall. And I think that's what I've learned the most in life, is that it's not about who you are. It's not about what degrees you have behind your name. It's about who you help. When you get there to it, and you can help anyone at any level. It doesn't have to be great. It can be little. It can be anything little. It can be a compliment. That, to me, is when you realize how full that fills you and also keeps you sober, keeps me maintaining my illness, keeps me where I need to be, because I know I have to be at a certain place to serve others.
Wow, that's perfect. That is just so beautiful, the way that you worded that. And Dr. Powers and I both are kind of looking, gazing at each other across the room, because it's what we do also each day. And I think we find meaning and purpose in a very similar way. Did you have anything that you wanted to add, Dr. Powers, for today's PI?
Yeah, so the first part was pretty hard, like looking at the goals that I set, because we're doing this every day. Every podcast is a new day. So I think I've got the COVID 20 pounds, and one of my goals was to lose 20. So now I've got the COVID 40 to go. So my goals weren't that great, but helping someone else, I really focused on that. So my son loves basketball, I mean, ever since he was little, like if he was in a store where there was a basketball, I don't know how he found it, but I would just listen for the dribbling, and there he was. So now he's 14. He's really good. He's already taller than me, which is great because unfortunately his dad is shaped more like a basketball than a basketball player. But I helped him by doing these goal setting exercises where, where do you see your life in 5 years, 1 year? So what can you do 6 months? We broke it down that way. And so he's been doing this thing called Air Alert, which is a 16-week program. And he's doing this on his own. It's a 14-year-old kid, he gets up from his Xbox or PlayStation and just does these like exercises. And a lot of it was helping him with the goals and saying, okay, look, if you want a 90% free throw percentage, this is how many you're going to have to shoot every day. And yeah, and it feels great to help somebody, but like every day to rebound for 2 hours, like honestly, sometimes it doesn't feel so great. Because wait till you're 50 and you're in this position, but it does. Like what you were saying, meaning and purpose in life is, I think, probably the biggest bucket that leads to happiness out of the 5 of PERMA. So well said. Agreed. What about you? How was your PI?
Yeah, so one of my goals that we set earlier in the year was to each month I was going to sign up for a race and I was going to achieve these medals through yesfit.com. And I have to admit, like, I'm getting the bling. Like, I got a really cool
they are really
Peter
cool medals.
Wendy competition pocket watch. It's so fantastic. And someday I'm going to have to share them on the show. But I've held to my goal of doing one of those each month. Right now I'm working on Beauty and the Beast, and I have a couple more days left to finish it. And I'm going to do it. It's going to be done by next Tuesday. So I'm doing well with that. That doesn't mean that it has prevented me from getting any of the COVID-20 that you're talking about. It's hit close to home too. However, helping someone every day is something that I feel fortunate to be able to do, whether that's on the employee side or on the client side. Really, I was a little concerned I might be a few minutes late getting here today because we actually had a client that was having a severe panic attack that actually passed out outside. We wound up having EMS contact it, which probably didn't need to happen, but it scared some of the other clients, and they ran inside and shared with the nursing staff that they felt like they needed to call 911. But we were able to kind of talk him through it and breathe him through it. And one of the things I was laughing at when Dr. McIngvale was talking about don't teach someone to breathe in the middle of the emergency. Fortunately for us, we do box breathing and we do meditation on a daily basis with our clients. So I was able to get him in a good place with just doing some work with him around breathing. Kept saying, I don't understand why my lips are tingling. What's happening to my lips? And so,
you're doing too much deep breathing.
Right, exactly. So we walked through that. But that was just before I got here. And it felt good to be able to help him and him not to have to do anything but just be with us in the moment, and we could get him through that. So I love doing these PIs. Dr. McIngvale, we use them with our staff, and we also use them with our clients. And so we are going to be sending you, normally if you were here in the studio with us, we'd send you home with the Positive Recovery Daily Guide to Thrive in Recovery, but we'll send that to you, to your work address, if that's okay.
That sounds great. Thank you.
For sure. So for next podcast, we're going to be focusing on day 9. That is a Jim Rohn quote, which is, you must take personal responsibility. You cannot change the circumstances, the seasons, or the wind, but you can change yourself. So as far as the PI goes, we're going to ask that you journal about any resentment that you might be harboring. This includes any directed inward at yourself, a type that can be uniquely painful and damaging. Ask yourself in the writing assignment what part you played, if any, in the incident that you created the resentment, and see what you can do to honestly let it go. When you journal, simply describe the resentment in a few words or a few brief sentences. Use the bulk of your time writing about your part or reflecting on how you can nurture forgiveness. Focus on changing your intentional thoughts and wish for the other person's well-being. So with this, like, the only things that you have control over are your own intentional thoughts, actions, including speech and chosen priorities. You're responsible for your life and yourself in this moment. So indeed, you are responsible for no one else. So hopefully next week's PI will be a good one for us to take a look at. I'm looking forward to doing it. And thank you so much, Dr. McIngvale, for being on today's podcast.
It was a pleasure. Thank you so much for having me on.
Thank you, guys. I know what I'm doing my resentment at. COVID-20. Anyway, thank you, Dr. Liz. And this is Powers and Denofa signing off.
Thank you for listening to this episode of Positive Recovery MD. Don't forget to visit positiverecoverymd.com to sign up to get your daily positive intervention sent straight to your inbox. Be sure to subscribe to Positive Recovery MD on Apple Podcasts or wherever you listen to your podcasts to receive an automatic download when a new episode drops. And as always, if you or someone you know needs help, visit positiverecovery.com or call 877-4SOBRIETY, which is 877-476-2743. We are here to help.